Good day, I'm Tian Tian. I'm the social media editor of the Parkinsonism and Related Disorders Journal. Today, we are very fortunate to have with us Dr. Dulski from Mayo Clinic, who has recently published a wonderful article in the Parkinsonism and Related Disorders Journal entitled Distinct Biological Underpinnings of Parkinson's Disease Motor Subtypes, a single-center study on pathway stratified polygenic risk scores. So, Dr. Dulski, welcome.
Thank you for the invitation. I just would like only to add that I'm indeed affiliated with Mayo Clinic Florida, and the research that I've published was done when I was there, but I'm currently based in Gdańsk, Poland, and I work at Medical University over here.
Could you tell us, how does this study investigate the biological pathways between Parkinson's disease clinical subtypes?
If I may start to say why we studied this topic at all. I think it's really important. So we all as clinicians face the striking heterogeneity of Parkinson's disease. We know that our patients develop symptoms at different age, they develop different symptoms, they respond differently to the therapy, they have different prognosis. So very often I wonder whether it's one disease or whether just there are many Parkinson's diseases that just share some commonalities. And that was the purpose of the study, to check whether these different clinical subtypes of Parkinson's disease, whether they indeed have different biological underpinnings. And our approach was to study the genetic variants of these patients. So we collected a cohort of 799 patients. We divided them into 4 clinical subtypes: tremor dominant, akinetic rigid, gait difficulty dominant, and mixed. And we performed GWAS study, genome-wide association study, and subsequently we did stratified polygenic risk score assessment. That is, we took the variants for GWAS study and we annotated some of the variants to known biological pathways that are known to be involved in Parkinson's disease. And that were 10 such pathways, including, for example, adaptive immunity, lysosomes, overall risk for Parkinson's disease, and others. And we compared each subtype versus the others. For example, tremor dominant versus altogether akinetic rigid, gait difficulty, and mixed. And we found 3 statistically significant observations. So firstly, the akinetic rigid subtype had the highest overall PD risk score. And secondly, that there was a striking difference in terms of adaptive immunity polygenic risk score between akinetic rigid subtype that had the highest and a tremor dominant that had the lowest. So they differed strikingly in our study, and that, I believe, aligns well with our clinical observation. We know that akinetic rigid is the most severe subtype with the fastest progression, earliest cognitive decline, most frequent RBD symptoms. On the other end of the spectrum, tremor dominant, which is considered mild phenotype.
Were there any unexpected patterns observed?
We didn't find any difference in terms of, for example, lysosome involvement, mitochondria involvement, which were assessed with the stratified polygenic risk scores, and which are actually known to play a huge role in Parkinson's disease pathophysiology. Perhaps the number of the included patients was too low to pick up some smaller size effects, or they indeed are not, they don't play such an important role as you thought before.
Very, very interesting findings you have in this paper. How do these findings advance our understanding in PD pathogenesis, and what potential do they hold for developing subtype-specific therapeutic strategies?
So I think that the strongest point of our research is that we support the concept that Parkinson's disease is rather a syndrome than a disease. So this is rather a syndrome that is comprised of different pathophysiological processes that converge into one clinical syndrome. And if that indeed holds true, I think it has tremendous importance for clinical trials. So when we research a drug with specific action, we would like to include patients that have the same disease, that have the same pathophysiological process. If we include patients with other processes, we will probably find a false negative result of our study. And I think if we look back on some of the trials from the past that didn't work out, perhaps maybe that was the reason that we didn't see any difference, because we tried some medication that worked for some patients indeed, but then there were patients with other pathophysiological processes involved, with other biological pathways involved, and that's why the studies came out negative. So I think this has serious implications for clustering of patients for the clinical trials, and also for selection of patients for clinical trials. If indeed a kinetic rigid subtype is associated with a stronger immunological dysfunction component, perhaps when we test some immunomodulatory drug, we would enrich the group of our patients with a kinetic rigid subtype rather than tremor dominant.
Very interesting. Are there any limitations of this study? You did mention about the small sample size. Are there any other limitations that you could see from this study?
The small sample size is the first limitation, and especially that we divided the patients into 4 clinical subtypes, and some of the subtypes, especially gait difficulty predominant and mixed subtypes, were really few patients included. And the second limitation is that all patients were of European ancestry, so that limits the generalizability of the findings. And also these patients were they lacked longitudinal follow-up. Most of them were assessed twice. So of course we know that some of the clinical subtypes, they evolve over time, and longer term observation is needed.
Given the observed involvement of the immune-related pathways, what future research directions do you foresee to clarify the role in the PD subtypes that you have mentioned earlier on?
I would say that we need larger studies, multi-center effort, and also multi-ethnic cohorts to replicate our findings. I think this is the most important next step. And secondly, we know there is some literature that actually PD subtypes, they differ in terms of immunological aspects. For example, there is a different neutrophil to lymphocyte ratio between a kinetic rigid and tremor dominant. They also differ in terms of some inflammatory or anti-inflammatory properties. So I think that we should add this evaluation of inflammatory markers, of anti-inflammatory markers, as a assessment for our studies, that it plays a role. And I would call this the 2 main important aspects. And also I think that if the immune system plays such a role in PD pathogenesis, at least in some subtypes, of course, pursuing medications that work especially on that pathway is very important. But also, on the other hand, if we look back, many medications, now a hot topic, GLP-1 receptor agonists, they also have anti-inflammatory effects. So that all adds up.
A really beautiful paper. And do you have any other comments you'd like to make?
I would like to thank my colleagues from Mayo Clinic, Florida, First, Professor Zbigniew Zolek, my supervisor and mentor, for including me in the study and letting me lead the writing of the paper. Also other colleagues, Professor Owen Ross, Mike Heckman, and many others.
Thank you and congratulations once again. And for those readers who would like to read this paper, it's in the Parkinsonism-Related Disorders Journal in August 2025. And the topic of distinct biological underpinnings of Parkinson's disease motor subtypes, single-center study on pathway stratified polygenic risk scores. Thank you once again, Dr. Dulski, for this interview.
Thank you very much for the invitation and for very engaging questions. And thank you, Mary Ann, for making it all possible that we meet various 3 continents, but we made it.